The next tissue proper, the next connective tissue that we're going to talk about. So we're moving from the connective tissue propers, the fibroblast-related tissues, to cartilage. And the major production cell type here is the chondroblast. There are three kinds of cartilage that I want to show you. This one is some of the most beautiful tissue that you'll see under a microscope. It's sometimes described as glassy cartilage because it has this kind of translucent appearance when you look at it under a microscope. This is hyaline cartilage, although it is difficult to see the collagen fibers here for reasons that you can explain at least at a basic level, right? Cartilage is a different type of collagen. There's collagen certainly in the matrix here. But what's more important here for me with you guys is to talk about the places in the body where hyaline cartilage is located. For example, it tells you here that the hyaline cartilage forms most of the embryonic skeleton. Okay, so this is not a trivial observation. Very important, and it's related to the next observation here, and here it is. As we get to bone and we start to talk about some of the things with bone, I'm going to do that today. At least a little bit, not completely, but I'm going to do a little bit of that today to get you thinking about compact and spongy bone and how bones are made. What you're going to learn is that there are two general strategies for making bone in the human body. Bones like the skull are made out, are actually formed in the embryology from these connective tissue sheets through a process called intramembranous ossification. The long bones in your body, so the bones we talk about whenever we're discussing growth and maturity, things that hormones do in bones, we're always looking at long bones when we do that. And all of those bones are made from hyaline cartilage models. So even the small bones in your wrists and ankles, the carpals and the tarsals, are made from hyaline cartilage models. And so this says that hyaline cartilage forms most of the embryonic skeleton, and that's true. So this process by which hyaline cartilage is converted into the bones that we have in our body today is a well-known developmental process of bone formation called endochondral ossification. And I'm going to show you that a little bit more as we proceed further. I'm going to introduce you some more to bones and stuff. So this stuff is the stuff of the embryonic skeleton. So as you're tracking the way bones are developing during intramembranous ossification, you'll see that cartilage is being converted into bone. And so what we find is the center parts of the diaphysis are the first places where this happens, and then the bone grows outward from those central or primary ossification centers. And then you have the ends of the bones where these centers form, and then the bone grows toward the primary. And so what you find as a person grows is that this stuff right here gets trapped between the bone that's growing from the shaft outward and the bone that's growing from the ends of the bones inward. And we call those growth plates. So the epiphyseal growth plates are actually hyaline cartilage. And it's more proper to say, in fact, that a bone grows primarily not because of the bone there. Certainly the bone has to replace the cartilage, that's true. So in some sense, yes, the bone is growing. But the spurt in growth, if you will, that we see during puberty regulated by hormone levels is really more cartilage growth. Because as soon as that cartilage is trapped between, as soon as this stuff that's trapped between those two ossification centers, as soon as the bone overtakes it and the cartilage disappears, there is no more growth. So we worry when kids break these epiphyseal plates, when they, do backflips off the couch in the living room, and they break the ends of their bones because they're still growing. And damage to these cartilage plates can cause significant problems in the distribution of growth. So you can end up with one arm longer than the other when that happens. In addition to the epiphyseal plate, this stuff showing up in as the embryonic skeleton is forming. As the bone finishes, and we'll see a picture of this today with the bones, as the bone finishes its ossification, and there's a line where the cartilage was, so you don't see the cartilage anymore, you will still have cartilage on the outside of the epiphysis of the bone. So where each of the bones meets the other bone in the joint, there's actually a cartilage lining softening the joint, if you will. And that is also hyaline cartilage that's left over from the development of the bone. So to say it forms most of the embryonic skeleton is a dramatic understatement in terms of its importance and distribution. So, as I said, these are related. This articular or hyaline cartilage covers the ends of the long bones in the joint cavities. It also forms the costal cartilages of the ribs. It is unusual in the human body for a bone to be joined to another bone by cartilage. Normally, bones are joined to bones by dense regular connective tissue, ligaments. However, in the sternum, we find that there are costal cartilages that attach the ribs to the sternum. And because you know already that these are avascular structures, you can understand and explain already why, when going into the thoracic cage, you would not want to cut the costal cartilage. Healing here would be very difficult. Instead, entry into the thoracic cage for heart procedures is normally done through the center of the sternum, which is a very highly vascular structure and heals very quickly. So the first 7 ribs have a direct attachment to the sternum, and then there are 5 more ribs, but only 3 of them attach indirectly. The last 3, or 3 of the last 5, which we call the false ribs, and then the last 2 have no costal cartilage attachment whatsoever to the sternum. So this picture will resurface again, and you've already seen it as you're learning your bones. You've seen it on the skeleton in the lab. 12 ribs attached, 10 of them attached by hyaline cartilage. The first 7 directly to the sternum, the next 3 indirectly to the 7th costal cartilage. Finally, the cartilages of the nose and the cartilages of the trachea and larynx are mostly hyaline. Now, there are 6 named cartilages of the larynx, and they are not all hyaline, but the big ones are. So in your voice box, the larynx, your voice box here, the large cartilage here that you can actually palpate easily is called the thyroid cartilage, and it is hyaline. It looks like this. The trachea itself has 20 C-shaped cartilage rings that support its lumen. So if you're going down the trachea from the larynx, if you're going down the trachea, there will be 20 of these C-shaped rings. The C is open, right? And it's open in the posterior aspect because that's where your esophagus is. So when you swallow, the rigid nature of the trachea does not inhibit your ability to swallow. If something goes down the esophagus, it's got room in those C-shaped hyaline cartilage rings for you to swallow. So this is the main support structure for your airway, at least in the upper respiratory tract. Hyaline cartilage keeps your voice box open, and it keeps your trachea open. It's like the ribs on a reinforced garden hose, keeping these tubes open. Hyaline cartilage, very important tissue in the body. The second one here is elastic cartilage, much less abundant, and you can see the elastic protein, the elastic fibers here, that spiderweb looking network in the matrix of the elastic cartilage. And this stuff also is part of the larynx, as it turns out, the epiglottis. So the epiglottis is one of the named cartilages of the voice box, and the external ear. So let me just point out to you, just make another statement about the epiglottis. We'll see it again this semester on more than one occasion. So as I'm teaching you all of these named cartilage of the larynx, I'll point this one out first. The epiglottis sticks up superiorly. It sticks off of the voice box on the front side. It sticks off of the anterior aspect of the voice box up this way. And it's made of this kind of elastic cartilage. It's very flexible. And whenever we swallow, our larynx moves superiorly. The muscles pull the larynx superiorly. And when that happens, the epiglottis, because it's bendable, closes the airway. So this piece of elastic cartilage is the primary way we prevent things from going into our airway whenever we are swallowing. And it is able to do that all of our lives because of its flexibility, the elastic nature of the cartilage that sits atop the larynx. Okay, the last one is fibrocartilage. And this is, fibrocartilage is very strong. The collagen fibers here create a very strong tissue. Whenever speaking about fibrocartilage, clinicians will use terms that I think an anatomy student should probably know. They're not written on this slide, but I will give them to you now. A fibrocartilage pad, especially in reference to the fibrocartilage pads in the vertebral column, these are not in the lab, right? It's all bones in the lab. You don't have fibrocartilage in there. This is living tissue and it's gone. These pads have, this fibrocartilage, have very thick rings that surround the cartilage pads. And those rings are technically called the annulus. Some textbooks will call it the annulus fibrosus, but you will hear this in clinical settings, the annulus. Let me see if I can get you interested in this. The annulus of the fibrocartilage pad is the thick covering around the cartilage. The inside of the cartilage is normally referred to as the pulp, P-U-L-P. Sometimes you'll see it referred to as the nucleus pulposus. But clinicians refer to these pads as an annulus around the pulp of the cartilage. So let me see if I can get you interested in it. The most common back injuries occur between L4 and L5 in this region of the vertebral column, and L5 and S1. And the easiest explanation for why this happens here as the most common back injury is because of the curvature of the vertebral column. So if you look at this skeleton we have in the lab, any skeleton, you can see this in any book, look at the figure in your book, you can see that in the cervical region of the spinal cord, there is a slight anterior displacement. So there's a curve in the neck where the vertebral column actually runs this way. It is an anterior projected curve in the cervical region. As you move into the thoracic region, the curve becomes dorsally or posteriorly exaggerated. Now, this is normal. Vertebral columns don't run straight up and down. They actually have curves in them. As you get to the lumbar region, the curve turns back anterior again. So you can see that here, a slight anterior curve in the lumbar region. Now, anyone who is looking at vertebral bones can tell that the lumbar bone has special characteristics. Lumbar bones have centrums or bodies that are much larger than their thoracic and cervical counterparts, right? And that's because most of your body weight from your hips superiorly sits here. It is said that the body's true center is the first sacral bone. And the body of that first sacral bone is a very important anatomical landmark. You've seen it already labeled? The sacral promontory. Yeah. So this is a very important spot right here. It's the body's true center. So everything superior to that is impinging its weight on that area of the body. So this anterior curve, even though the bodies are very large, designed to support that pressure, even though they're very large, you still have an unreasonable, frankly, an unreasonable amount of pressure placed in this area of the vertebral column all the time. And so it is a very common problem, the most common back problem, to create damage, whatever added stress is put on the back, to create damage here in the intervertebral disc between L4 and L5 and between L5 and S1. Now, the way you know damage has been done is because of the pain that is produced here. And the pain that is produced is normally caused by the leakage, it's not really a leak, the protrusion of the pulp through the annulus of the fibrocartilage, impinging on the dorsal roots of the spinal nerves that are in this area. So these are nervous system things you don't know yet, but I promise you, you will be interested as we get there. And I'll bring this cartilage story up once again. The annulus and the pulp here for the fibrocartilage. As the spinal cord gives rise to the nerve stuff that comes off of it, there is one connection that comes off of the dorsal side and one connection that comes off of the ventral side. In anatomy, it is a beautiful thing when there are no exceptions to anatomy rules. And this is one of them. All of the information coming off the dorsal side is sensory in nature. So everything that is coming to my cord that I will process on the sensory level comes in on the back side. You follow me? On the dorsal side. So if you do damage to this fibrocartilage and it impinges out on that dorsal side, your body is going to interpret that as pain coming from where those nerve fibers actually end up. Normally, it's down the back of your leg as part of the sciatic, tibial, and fibular nerves. So in this L4, L5 region. Okay, so the annulus of the fibrocartilage is damaged in back injury, and now you have a little bit more in your mind to explain what's going on there and the reasons why this is an area for damage to the intervertebral disc. The second area listed here is the pubic symphysis. So the coccybones articulate with each other anteriorly. And this is, again, an unusual connection. We expect bones to be connected to bones with ligaments. But instead, the two pubic bones are actually joined together anteriorly by a piece of fibrocartilage. It looks just like the fibrocartilage that you find in the back. And then finally, the menisci of the knee. And we'll talk about these. I will get to the knee joint extensively. So guess what we're going to find when we start talking about the knee joint, or synovial joints, and the synovial joint of the knee in particular. We're going to find, look, there's some cartilage on the end of the femur covering the bone. And I'm going to ask you, where did that come from? It's going to be labeled articular cartilage, and you're going to say, that is leftover hyaline cartilage from endochondral ossification, where the bone was developing. And then I'm going to say, look, there are two C-shaped cartilage pads that sit on the condylar surfaces of the femur. Right? The femurs have condyles and they have epicondyles. Are you guys starting to see why the skeleton is important to get? It's everywhere, right? We can't talk about anatomy without it. So on the distal end of the femur, you have two condylar surfaces. And those condylar surfaces articulate with the condylar fossa of the tibia, right? The femur sits in the two surfaces on the tibia. There is no weight bearing on the fibula. If the femur were to sit on the tibia, would it be bone on bone? No, it would not. It would be articular cartilage on articular cartilage, hyaline on hyaline. But that's not the way it sits. Instead, there are menisci, fibrocartilage discs, that sit there, C-shaped, so that the opening of the C is medial. The opening of the C is medial. So the two C-shaped menisci sit in the condylar surfaces like this. Why is it C-shaped and why is it open in the middle? How do you damage these things? The way you damage the menisci of the knee is you push the condyle of the femur out of its articulation with the condyle of the tibia. Because those thick regions of the fibrocartilage keep the femur in place. They serve as cushion, and they also serve as stabilizing features for this joint. This is why your femur doesn't roll around like this in your knee. It doesn't move forward, doesn't move backwards or side to side, in part because of the menisci. Now, the knee doesn't take the menisci as the only stabilizing feature. The knee actually puts cruciate ligaments through the condylar fossa and collateral ligaments on the medial and lateral sides to help support this. But these are major, major clinical issues for people. Anytime you're in a sports injury scenario and you're talking about knees, this is going to be one of the first questions. Are the menisci damaged? Cartilage damage is most of the time not fixable. The cartilage has to be removed if it's causing a problem. The ligament damage is normally repairable. And you as anatomy students can already explain the reason why. Why do the menisci fibrocartilage pads have to be removed if they're damaged, and the anterior cruciate ligament can be replaced if it's damaged? If you don't tear the ACL and they leave it alone, can it repair itself? That's right, Jared. How do you know that? It's vascularized, yeah. The cartilage is not vascularized, so it's much harder for the cartilage to repair within the knee joint. All right, the next on the list is the bone, and we're going to do this from a couple of different, we're going to do a little bit more than your histology thing here, because I'm not coming back to this intro bone stuff later. So I've already introduced some of this to you. This is a picture of compact bone. You should be aware that there are actually two distinct varieties of bones found in all of the bones of the skeleton. So this is compact bone, and you can see over here a bone that it is locating this stuff in bones. And so what bone is that, young people? That is the humerus. It is indeed. And is this an anterior or posterior view of the humerus?
Anterior.
How did you know that? That's right.
Because of the capitulum trochlea right here.
Okay, so the trochlea, you can see, yeah, and the capitulum, but there's an easier way here on the distal end to tell this is the front side.
The olecranon fossa.
Yeah, the olecranon fossa is a posterior fossa, and it's easily identified. That's where the olecranon of the ulna goes, and it's on the back side of the humerus. Okay, so you're identifying bones already. I like the way that's going. If you cut the bone open, you will find that you will have both this kind of bone and spongy bone located in all the bones of the body, including the long bones. So here is an example. This is the humerus, as you've already told me. And there are a couple of sections taken out of this to teach you some of the pieces and parts of the bone that are critical. All right, so let me point out a couple of things that you know already. You already know what this is. What is that right there? It's labeled for you here, but I'd like to know what it is. If I looked at it under a microscope, what would that look like? I thought you knew that. I told you just a moment ago.
Fibrocartilage, hyaline cartilage.
That's hyaline. Yeah. Where did it come from?
During the initial growth.
Right. During the bone development. So I don't have that picture here to show you, but I won't leave you out of anatomy without it, so it'll come later. But I've already told you, endochondral bone development uses hyaline cartilage as a model. So when you finish, you still have hyaline cartilage on the end of the bone. So where these synovial joints are in the shoulder and the hips and the knees, and the ankles and the wrists. There's hyaline cartilage between those bones. What about this one? What is the epiphyseal line?
Where the two growth plates met.
Mm-hmm. Is this bone going to grow anymore? Why not?
They came together.
Why?
Because they came together.
They came together, yeah. The ossification center that was here and here have now fused here. I would know that the bone is still growing if what were present here. What would need to be present here for me to say the bone is still growing?
Cartilage.
Cartilage. Yeah. What kind of cartilage?
Fiber.
Hyaline. Yeah, hyaline cartilage would be here. That's right. Okay, so these are things you're picking up. The epiphysis, the diaphysis. Notice in the epiphysis, so I'm going to cut a piece of the epiphysis out so you can see what's there. Notice you recognize here around the exterior of the epiphysis, there is in fact compact bone. Can you guys see the compact bone in here? The compact bone has this very typical kind of pine tree looking arrangement.